The last topic that I'll be focusing on today is soft tissue reconstruction of the distal third of the lower extremity. Soft tissue defects of the distal third of the lower extremity are notoriously hard to cover for several reasons. First, the local availability of tissue in the distal part of the lower extremity is extremely limited. In addition, defects on the plantar surface of the foot need to be extremely durable as they must tolerate weight bearing. Microsurgical tissue transfer has greatly increased our options for soft tissue coverage. However, this requires highly specialized and expensive equipment and specialized training. Despite the difficulty, coverage of these defects with local vascularized tissue is possible in many circumstances, as long as one has a good knowledge of the anatomy as well as a good knowledge of fundamental flap design principles. Options for soft tissue coverage in this region include the reverse sural artery flap, which we'll be discussing in detail in this talk. In addition, for smaller defects, local fasciocutaneous flaps are possible. And for defects for which no other options are suitable, cross-leg flaps can be performed. We will provide links to additional discussions on local fasciocutaneous flaps and cross-leg flaps at the conclusion of the course. The reverse sural artery flap, while being the most technically challenging of the flaps that we'll be discussing today, is a versatile flap that can provide durable soft tissue coverage to the distal one-third of the lower extremity, as well as defects around the ankle, calcaneus, and foot. The flap is a fasciocutaneous flap from the posterior aspect of the lower extremity that relies on blood flow from perforating branches of the perineal artery distally with retrograde flow proximally to supply the skin petal of the flap. A thorough understanding of the anatomy of the blood supply to this flap is critical to its success. The superficial sural artery is a small vessel that accompanies the lesser saphenous vein and sural nerve as they descend between the medial and lateral heads of the gastroc muscles deep to the fascia. At around the midpoint of the leg, the neurovascular bundle pierces the fascia and continues running distally superficial to the fascia. The diagram here illustrates the normal anterior grade blood flow through the artery. The flap is termed reverse because the blood supply is transected proximally. Distal perforators from the perineal artery that anastomose to the superficial sural vessels distally then provide blood flow, which then travels in a retrograde fashion to supply the proximal skin paddle. The location of these perineal perforators is approximately 5 to 7 centimeters proximal to the lateral malleolus. The success of this flap hinges on carefully preserving the blood supply in the design of the flap. The retrograde blood flow from the distal perineal perforator becomes weaker the further proximal that it travels. Therefore, there is a limit to how proximally the skin paddle may be designed. This limit is roughly 5 to 8 centimeters from the popliteal crease. The theoretical pivot point of the flap is the perineal perforator itself, roughly 5 to 7 centimeters proximal to the lateral malleolus. As illustrated here in cartoon format, the skin paddle corresponding to the size and shape of the wound is designed on the posterior aspect of the leg, and this flap will be elevated along with an adipofascial pedicle surrounding the blood supply to the flap, as illustrated in green here. This image demonstrates a clinical example. The estimated location of the perineal perforator is marked out. The skin paddle is designed and denoted as this blue circle. The pedicle, containing the superficial sural vessels and lesser saphenous vein, is estimated to lie between these two red lines. This tissue will be carefully preserved during the elevation of the flap. The skin is incised around the skin paddle. At the junction of the adipofascial pedicle and skin paddle distally, great care must be taken to not incise deeper than the dermis. Proximally, the lesser saphenous vein and sural nerve are identified and ligated. The superficial sural artery is usually too small to be reliably visualized and is assumed to be running with the nerve and vein. Here the flap with its adipofascial pedicle has been elevated from the surface of the gastroc and Achilles tendon and rotated down to the lateral malleolus. This flap has been reported to have a relatively high rate of venous congestion and partial flap necrosis. In order to improve the chances of flap survival, a delay procedure may be performed if time and circumstances permit multiple trips to the operating room. The delay procedure involves ligating the sural nerve and lesser saphenous vein proximally and partially incising around the border of the flap. The flap itself is not elevated. By ligating the proximal blood supply, flow through the retrograde pathway increases and choke vessels dilate, resulting in a more resilient, robust flap.